Thank you very much for inviting me coming here to talk about UVM. I will try to show you as much as I can. We are working on many different fields in UVM, and we try to cover them all. I have no problem to be interrupted during the presentation for any questions. Then feel free to let me know if you have any doubt or anything that wants or needs to be clarified a little bit more. Okay, Dr. Hala previously described very well the UVMs and how it has been the evolution of the UVM. My presentation will go a little bit more on clinical applications, particularly on the applications that are taking profit of the side-by-side wide field we can provide with the newer hardware. The UVM, as Dr. Hala said, has been used extensively from the early 90s when it has been introduced by first time by Allen and Foster in Canada. Here are a list of what are the advantages of the newer UVMs in comparison with the previous ones. We are working with the larger displays. It's not just a zooming factor. It's not a question just to be enlarging the picture. It's just through more the pixels density on the display we are showing. It's almost 45% larger than the previous one. We are also refreshing faster, means the speed of the transducer moving or scanning the eye gets almost 50% larger than before. We are offering wider and deeper penetration, the whole anterior segment in one image. That was a limitation that we had before. Means that so far today we can show the whole eye, the whole anterior segment of the eye, in only one image. We don't need to be recomposing images. There are some big improvements inside in the core of the software, which turns the signal, the noise to radio signal better than before. And we are scanning farther away. Before we were forced by the poor penetration to be scanning almost a millimeter away from the cornea, producing scratches. It was very often happen. Now we are scanning 10 millimeters away from the cornea, means that we are in a very safe procedure, even though we are still needing immersion. Those are the three examples of what we can do right now. The two at the top are covering side by side. And as you can see, we can have a very big detail of the whole anterior segment of the eye. And we are also configuring the unit to work on an angle configuration as we have been working before, although showing larger images of the posterior, of the angle. Okay, these are different applications or miscellaneous applications we are bringing to our software. As you can see, this is what we call the Pro 2000 nomogram. It's an angle evaluation. So far today, the anterior chamber angle has been evaluated by the angle caliper, just telling it's a 15 degree, or it's a 25 degree, or it's a 40 degree, which is a concept that is very difficult to follow. We are trying to match a regular geometric figure as the angle caliper, which is a triangle, on an irregular anatomical anterior chamber angle. You know, the anatomy is not regular. It's curved lines that we're trying to match with a straight line. This is why years ago, and based on what Pavlik defined when he invented or presented the UVM, it has been done the Pro 2000 nomogram. Instead to be evaluating how open is that, it's telling you how big of a space the aqueous humor is going to have to flow out. In other words, angle recess area going to provide you an idea or how open or narrow is this angle. Here you can see a very narrow angle, and so is the red area that has been semi-automatically detected. This software requires for the user to identify the scleral spur and to identify the iris root. Once you tell the system this is the scleral spur and this is the iron root, the system will automatically fill the angle recess area, providing you a little bit more information than 15-degree angle. It often happens that when you receive a report from somebody who has evaluated your angle, it says opens soon, very ambiguous way to say, or it's a narrow angle, how much narrow? Or is it a wide angle, how wide is the angle? Here is an objective evaluation. We are providing a number. Do not ask me about what is a number from where we can consider an angle abnormal or normal. There is no zero reference here. There is no baseline. This is why the quantitative analysis is important to be done over time when you follow up. For example, if it is a patient that requires a hyoidoplasty, and you want to check how much the angle got open after that procedure. It becomes very interesting on iris plateau. In this particular iris plateau image, as you can see, the ciliary body is anteriorly rotated. It's forcing the iris to bore vertical. The iris usually bores horizontal. But in this case, the rotation of the ciliary body, it's forcing the iris to bore in a vertical way, forcing at the same time the iris to immediately turn horizontal, going to the center of the eye of the anterior chamber. In the last CIRO meeting in Edinburgh, Michel Puech from Paris, he presented a very interesting study about the incidence of iris plateau on the angle closed population, let's call it, universe. On many angle closes that you will going to be seeing on your practice by the slit line, 50% of them going to have some kind of iris plateau anatomy, or either trend, or he classified in 4 different ways. Here we have the Pro 2000 evaluating the iris plateau. Okay, another applications we can take profit of the UDMs is the canaloplasty. This is a stem canal image of 30 months post-op of a viscocanalostomy. Usually the stem canal has a dimension of 100 microns by 40 microns. Usually it's collapsed. There is no interface that the ultrasound on any other imaging device can detect. When you dilate it, or either by visco or by the catheterization, you can see an image like that. Another application that is very often present, particularly in hospitals and people who treat very serious glaucoma cases, is the amendment of the bulbs. We are implanting bulbs. There are many kinds of different bulbs to be implanted. Here you have a Molteno bulb. The 2 images are showing you. The one up on the left is showing you a cross section of the tube coming of the posterior chamber. This is something that the doctors want to avoid because the iris most probably going to be occluding this tube. But here you can see, and you can follow all the way of the tube on a cross-sectional way on the upper left, and tangentially on down at the bottom on the right part of the picture. If you see that in one way we're cross-sectioning the tube, and the other way we're getting all the way along. There are surgical complications on standard cataract surgeries. Look at that 6. It's just miscellaneous. That the 2 ways or the 2 orientations of the probe, one is tangential from inferior, is showing you the beginning of the anterior chamber and how the iris is interacting with the chamber. Meanwhile, at bottom right, you can see a cross-section of the cyst showing you or bringing you an idea how much this cyst is impacting the volume of the anterior chamber. Taking advantage of the wider coverage, some refractive applications are new for the UDM. Every IOL implant may take some benefits. I'm not talking about normal cases. 9 or 8 out of 10 of the cases you're doing cataract surgery. But there is always 1 or 2 out of those 10 that is or has a tilt lens, or the haptics are not in place, or the lens is not really responding in the same way that the other 8 or 9 patients out of the 10 that you have done surgery. Also, the phaco-refractive implants, which are going to be extensively talked in the next presentation. And finally, accommodative IOLs with the ability to show motion inside the eye. Here is a very simple example of how we can evaluate an IOL. On the left, you see an endophthalmitis. I think it's not necessary to remember you that you cannot even see that patient. You cannot even look at his eye, at her eye, particularly this wound one. But even having an endophthalmitis and having no view of what's taking place inside the eye, you know that the lens, it's a very old PMMA lens, is still on place. She's still having 2 chambers, even though the synergy of the iris is doing not very good. Down on the right is a very simple standard IOL, normal, monofocal, right in place, working fine, nothing really to remark. Here is another IOL in a Marfan, in a subluxation of the crystalline lens. There are 2 projections, 2 different scan sections. One is on the temporal superior, which is the place where the lens trends to go on the Marfan, or the displacement of the lens go, the subluxation. And of course, if you remove a subluxated lens and you implant an intraocular lens on the subluxated back, you're going to have a subluxated IOL, which is the case. Thanks God, the pupil is still being covered by the optics of the lens, meaning that the result of this patient is still satisfactory. Meanwhile, when you rotate, you're getting perfectly sectioned, and it looks like even a small tilt that looks perfectly normal. Here are 2 more examples. Up on the right, you see an hyphema. The hyphema, and probably not necessary to remember you that you are not seeing nothing. You are seeing a red eye. Well, you can see and evaluate this hyphema, knowing that there is a almost 360-degree disinsertion of the iris. And you can also see that the blood is kind of organizing and coagulating inside the eye. And also you can see that there is a small pediculum of iris on the right of the picture. Meanwhile, down at the right, this is the first attempt that we have done years ago to display motion on an accommodative IOL. This is a crystal lens, this is the Petrov lens. And if you see and look at the picture for a while, you will notice that when the eye is changing a little bit its orientation, a little bit angle, there is a difference, distance between the iris plane and the lens. That means that this is the 2 different positions that this eye is using to near vision, for near vision, and for far vision. We will go extensively later on that. Very simple way to evaluate an IOL is just getting an horizontal and vertical cross-section. In this particular case, we are seeing the first one on top, where the lens looks pretty well centered, even a little bit out of the haptics. But when we switch and we change for the vertical orientation, we clearly see that the sonula has been disrupted, and the lens is just leaning back, or trying to go back on the posterior chamber, creating what is being called the Z syndrome, to clearly see position of the lens inside the anterior, inside the back, if there is any back remaining. Well, the back is remaining, probably the sonula over. Finally, this is an iris clip lens, anterior chamber phaco-refractive IOLs. If you notice and you take a look for a minute on the picture, you're going to notice that the ciliary body, particularly here, is contracting. We were trying to push some accommodation to this patient, in order to evaluate the bolting of the crystalline lens and how big of an impact it's going to have the natural crystalline lens change of the curvature during accommodation or how close it will get for the implant, which is fixed on the iris. It seems that there is no really affection of the bolting of that lens. The bolting remains in the safe side, no matter what you do. Okay. This is not the end of the presentation. Just I'm splitting the presentation because there are too many video clips. And the next topic we're going to be talking is about phaco-refractive IOLs. It's what's being known as ICLs mainly. ICLs are manufactured by Star, company in the US, which is growing very fast because it's probably the only solution for the high myopes that cannot go through the refractive surgery. That represents a good option for the surgeons, just having a patient that needs some kind of correction other than contact lenses or frames. But ever since they have been implanted, almost 20 years ago they started with ICLs, they found that there is no correspondence on the external biodimensions of the eye with the internal sulcus to sulcus. I mean, they have been using Y-to-Y, limbus to limbus evaluation to say, okay, this is a big eye, this is a 10.5 eye, let's use it an 11 millimeter lens. There is no correspondence on this measurement with the sulcus to sulcus where the lens is going to be implanted. That means that if we have been measuring or they have been measuring in the wrong way. This is why UVM permits us to see what's the size between sulcus to sulcus. And this is what we will be showing you now. One of the major concerns is sizing. UVMs offer the option to measure the sulcus area where the lens is going to be implanted. We are measuring exactly where the lens is going to be implanted. And it also provides useful information once the lens is implanted. Once you have it implanted and you are not happy with the bolt, or it's too much bolted, or it's really no bolt, you may be able to tell why this lens is having a problem, this patient is having a problem. Don't try to see the four of them at the same time. It's horrible. It was a very bad idea to have the 4 video clips running at the same time. Let's go one by one. Here, up on the left, this is what is being considered a normal ICL. The bolting is this distance between the anterior capsule and the back surface of the lens equals a corneal thickness, about 500 microns. This is being considered ideal. We can also see here the haptics, the very end of the haptics, the foot plates that are very well placed on the sulcus. It's being anchored on the sulcus, and that forces the lens to bolt, creating a space inside the eye which is not present before. If we go to the second one, down here on the left, you notice that the bolting is very high. It's almost 3 or 2.5 corneal thicknesses, making a very risk situation over here in the angle. It's pushing the iris up, and somehow it can close the anterior chamber angle. Then instead of a solution, you are creating another problem. This lens probably has been oversized for such a given eye. Let's go to down on the right, where there is no bolting. We cannot see the anterior capsule of the crystalline lens because there is no space. The lens is full contacting the anterior capsule of the lens. The lens, the ICL is full contacting the anterior capsule of the lens. What does it mean? This patient, sooner or later, more soon than later, is going to have a cataract. Anterior subcapsular cataract going to begin, and let's pray to have a long time until this patient needs to receive cataract surgery. Finally, on up at the right, you can see the detail of the lens coming to the sulcus area and how it's interact with the anatomy over there. You see the haptics and how it is leaning on the ciliary body. This is a very nice one, and it looks pretty nice how the lens is creating its own space inside the eye. Okay, but in order to evaluate properly a pre-op and a post-op ICL surgery, we need, for ICL or any refractive surgery, we require alignment. Ultrasound, it's different than any other imaging device or imaging technique using anterior chamber or using in ophthalmology. We are used to get the joystick with X, Y alignment, then there is an autofocus and clack, picture is done. There's no need for alignment. In the ultrasound, it's not the case. In the ultrasound, it's you and your probe and the eye. Depending on how well aligned you are, you can have a lot of information that is not accessible to other media. But if you are not properly aligned, you're probably going to take wrong conclusions because you're going to take wrong measurements. You're going to get confused about what you are seeing on the eye. There are no other indications that you are properly aligned than looking at for the picture. You must align your images depending on what you are seeing. Any correction of the position of the probe must be done seeing the picture that is on the monitor. There is no other external reference that's going to guide you and tell you are right, you are not right. You are forced to look at the picture. We also need to be considering and remembering what is the anatomy looking like on an area we are going to be measuring. And then once we collect the images, we may need to select which of the pictures that the system has been capturing are good enough to be measured. We need to validate images. Okay, this is the goal on any ultrasound wide to wide. We need to get a picture like this one, a stable image over the old clip, which is going to stay properly aligned along the 50 frames that makes one clip. I am talking about the son of the ViewMax. These are 2 3-dimensional images of the sulcus area, the ciliary body. The one on top, it has been done by Goodhoff many years ago with the old UVM, the Humphrey UVM, Paradigm UVM. And this one at the bottom, it's a newer one done by the ViewMax, showing you how complex is an area that we are probably going to try to measure. Then we won't be finding a clear reference on both sides to say, hey, it's from here to here. We may need to work around that because it's not clear one neat and clear place where you will be placing your caliper. That's what we call the landmarks, something that Dr. Hala showed before. Those are the landmarks, and let's go directly to the picture because here is text and it's boring. It's going to be a little bit more interesting to see that. What are what we call the landmarks for alignment picture? The first critical one is you must be horizontally balanced. In ultrasound, the balance of an image is definitive in terms of measurement, in terms of imaging, in terms of clarity, in terms of alignment. If we are unbalanced, probably going to be a very good picture, but it won't be a good picture to be measured. You won't be able to take good conclusions. First landmark, horizontal alignment. The iris plane horizontally balanced between 10 plus minus 1, which are the reference we have here on the left. 12 plus minus 1, which is the focus area of the equipment. The equipment provides you a focus distance plus minus 1. You must place the area to be measured inside this strip. Second one, you must be able to draw a vertical parallax that's going to be joining the epithelium, endothelium, anterior capsule, and posterior capsule. Joining the apexes of all those curves that we are crossing by, it must be a straight line. Finally, third landmark, the posterior capsule. The posterior capsule is the ruling one. The posterior capsule acts like a pendulum. When we are aligning through the pupil, the minimum space that the pupil provides us to pass through, which show and will revert on a very good picture of the posterior capsule if we are centered and in the middle of that and actually aligned. That means that we will see the posterior capsule, but we should take the largest posterior capsule image over the clip. Finally, a good sulcus reference seems to be pretty easy to understand. This is a very good picture, but it's not properly aligned. We have a very nice details of the sonula over here, that we can identify the sulcus over here, but we cannot identify anything on the other side. And look at the posterior capsule. This is not the vertical parallax line. This line is completely, breaking in parts. Okay, once the properly aligns are captured, we take 6, we discard the largest, we discard the smallest, and we average the remaining 4. This will provide a very accurate clinical measurement of the sulcus. I'm not telling you that we are just having the truth, because it's a very irregular area. One important thing also to remember when measuring sulcus to sulcus is what's being called the spiracle sulcus. Sometimes the ciliary body is contacting the back surface of the iris. If it is contacting, it's creating a virtual space that if you implant a lens there, it's going to recreate this space. It's a virtual space that looks closed or looks not available at the time. In this example, many people are going to train to place the caliper on the first arrow, the arrow on the left, but the sulcus is ending here on the second arrow. And a very good help on that is the end of the pigment epithelial layer. As you can see, the pigment epithelial layer is ending at the second arrow. That's the real sulcus. That's where the real sulcus is. Those are sulcus to sulcus measurements, 3 different images of the same patient, 3 different measurements, just showing as an example. Here it comes a very important part of what I'm going to be talking today. The other one is accommodation, but now we're going to talk about effective lens position. And it all began when we started to simulate how an ICL is going to be looking like inside an eye, a major eye, a pre-operational image. And here is Carlos Dovisolo's nomogram, the doctor working in Milan in Italy. His programmers created kind of a simulation looking at, okay, if we have a given eye, let's simulate how the ICL is going to be behaving inside the eye. And that brings us to the next slide. It's also served us for calculation. We can calculate the size of the ICL to be implanted, and if it looks too big, we may see how many difficulties, or what are the difficulties that this lens is going to have inside the eye to create its own space. But here it comes. What we found doing many UVM exams, it's different eye shapes. If you look at this eye, it's a big lens. The iris is just angling up, just pushing up, kind of a closing anterior chamber angle. It's completely normal. And down here, we have a different shape. Both are normal patients. Probably the patient on top corresponds to a hyperop because of the thick lens. And probably the patient at bottom, it corresponds with a myop because it is flat. You see the iris is completely parallel. The lens thickness is smaller than the one before. Till here, everything is okay. Big guy is a myop, small eye is a hyperop, and we are all happy. This is not the case because we found that there are myops with this shape and hyperop with this shape. In other by 8 refraction circumstances, which gonna decide or forces us, or we're gonna decide to implant an ICL, and an ICL in the eye on top gonna have a completely different, easy way to create its own space depending on which eye shape you have. In other words, think about the slide that I showed you before. Think about this ICL simulated on the 2 other images. It's clearly going to have a better, easier way to fit down here. If the ICL must to be fit here, it's going to push a little bit more. You're going to have some more problems on the corner. You're going to find a much easier way to go in the picture shown at bottom. That was about an ICL. But what about the standard IOL? And the standard IOL, look at the picture. These are the same 2 pictures before. Look at the position of the equator here and here. And look at the position of the equator here and here. If I remove this cataract, the distance between the equator, which is going to be the anchoring vector for the bag, where the IOL is going to be implanted, going to stay almost a millimeter away from the iris plane. Here is the equator, here is the iris plane. If I look down here, here is the equator, clearly closer to the iris in this bottom picture than the one on top. As a simulation, or probably as a dream, I just put on the right 2 images of one of those intraocular lenses that you control in your slit lamp, where the lens is a millimeter away from the iris, from the pupil, and there are some other lenses that you see them just contacting or just almost occluding the pupil. This is being called effective lens position, and is the holy grail of the intraocular lens power calculation. Nobody can control if the lens is going to be sitting here. Where is my mouse? Here. If the lens is going to be sitting a millimeter or 2 millimeters away from the iris plane, or the lens is going to be sitting just right after the iris plane. The refractive optical diopter incidence of this position is going to be determined, hopefully it's going to be determined, and probably advanced into something that is not yet proved. There are 2 studies already started on that, about a pre-operational image, given image of the eye, given shape of the eye, and how the lens is going to be behaving after implanting. This is why we're working on software called eye modeling. We're trying to identify through just indicating some points on the eye, a kind of wireframe of the eye, which will provide us an idea of how the eye is going to look like, or how is the interrelation between the anatomy inside the eye on a given patient. Steep eye, flat eye, myopic, hyperopic. It's a whole world to be discovered there. And I think that this is here is some miscellaneous cases that I think that you're going to like it. It's an implanted ICL, just nothing to remark as a video clip of that. Next one is showing you the iridectomy. You can see here, this is the iridectomy. It's coming on the loop. Here is a detail of the ICL coming on the eye. And then I'm coming to this one again because we already left ICS, because I have a very nice one. Here is a very nice case. This doctor showing up and saying, hey, I already implanted that ICL 2 months ago, and the patient is having perfect view, very happy. I'm seeing some bowing of the iris. Yeah, clearly. It's an ICL that has been implanted upside down. Then the haptics, instead of anchoring on the sulcus, up, they are all the way around. They are pushing up the iris on the periphery. Nice case, but nice to be shown, not to be displayed here. It's not nice for the patient.
It works.
He's probably going to need to receive a cataract surgery pretty soon. And the shame was that it has discovered 2 months after. Okay, let's switch now to accommodation. Why it is saving the file? I didn't save the same. Okay. And here is one of the other hot topics where UBMs are becoming, or are being used recently because of the side-to-side coverage and wide-to-wide image. It's going to take a little bit to load this PowerPoint because it's plenty of images, which I think is going to keep you a little bit up. It's if I show you text, it's going to be very boring. Images are really, come on, here. Okay, we're working actively on accommodation, not because we think we're going to be discovering anything on accommodation. Accommodation has been largely studied by many different researchers on many different aspects. There is a clear understanding that almost all of the processes that are involved in accommodation are being known. The problem is that nobody was able to show them on live, on a human eye, as we're showing now. If you see the picture on the clip, it's a very good example of what's taking place inside an eye when you are switching to far to near vision. A very simple conclusion says there are 2 places where we need to look. One is the crystalline lens shape changes, and the other one is taking place on the ciliary body as I am pointing to you. The changes on the crystalline lens are mainly on expense of the anterior capsule. The anterior capsule is the first one you were going to remove doing a cataract surgery. Means in order to replace that accommodative ability for the patient, keep in mind that you are just taking out probably the structure that is moving the most during the process of accommodation. Second area to see is the ciliary body and how the ciliary body is moving. The ciliary body is moving inward and forward. Meanwhile, many people have been thinking, and probably many of you, as we have been doing, we thought that the ciliary body was contracting inward only. It's not inward only, it's inward and forward. It's not only closing or making that ring smaller, it's just moving, pushing anteriorly, together with the whole anterior uvea. I mean, there are an iris bowing, there is a crystalline lens change on shape, and there is a clear shift of the ciliary body inward and forward, which is very understandable that it's forward and inward because it's following the anatomy, it's following the sclera, where it is inserted or where it is tied or connected to. Same video clip example, probably showing more movement on the ciliary body than changes on the lens shape. It's still changing some lens shape. It's not that much bowing of the iris. We have found a variety of those, but there are common facts on almost all the eyes. The lens, equator distance, equator diameter gets smaller, the lens thickness gets larger, the angle to angle gets smaller, sulcus to sulcus gets smaller, anterior chamber angle gets shallower. There are patterns that are clearly telling us what's taking place, and finally we are able to see what's taking place inside the eye during the accommodation. That reverts us to think that Hermann von Helmholtz, 150 years ago, he already described it perfectly what's taking place. There are changes in two areas, crystalline lens and ciliary body. That's the same thing that we have seen before. Probably there are some other factors taking place here that we are not controlling so far. Okay, anatomy, that's something that we've shown before. If we are aware about what we are seeing, what we are measuring, we're going to make something easier to understand. Here is a nice image of the electron microscope of the sonula, insertion of the lens. This is miscellaneous, it doesn't really make any impact, but it's nice to see how those sonulas look like on the eye under the electron microscopy. And down there is the sonula images that we can show with the VuMax, which makes it nice and makes us think about what are the mechanisms that are taking place on that. Coming back to Helmholtz, and also described by Goodhoff many years ago, there are changes on the ciliary body that includes the ciliary body muscle and the ciliary processes. Those changes are clearly explained that it's moving anteriorly and interiorly. Means there is a movement inward and a movement forward. Okay, here is one fact that has been discovered recently. Look at the video clip on the loop. It's going to be running on the loop. And look at this area. The thicker line, which is at the end, that's the vitreous base. That's clear. It's known. It's present on all the patients. Well, what happened here? But there are some. Okay, just one second. This is posterior sonula. Look at those lines that are coming through on top of the vitreous base. Those are posterior sonulas. Posterior sonulas has been described based on cadaveric findings. Has been never described functionally and on live mode. I mean, it's the sonulas that are tied from the ciliary body to the pars plana, which I am sure plays some role on the accommodation. Depends on how strong they are, how are they holding the ciliary body. It's going to have an impact on the final results of accommodation and the human variability in accommodation that we see in different patients in different ages. Also another factor that is probably going to take place. Take a look on that picture and see the ciliary body, how it is moving. It's contracting and decontracting, moving forward and backward. You probably noticed that the sclera is also moving. Something that we were considering the sclera as a very rigid, non-flexible structure. And this is one picture, but this is another picture of the same, it's not the same patient, it's a different patient. But look at, wait until my lazy computer wakes up. Okay. Now the sclera is moving. It's clearly moving. It's clearly bringing or creating the space for the ciliary body to be contracted. This is perfectly in consonance with the theory of Zdenek in California, who probably some of you remember he made those 4 relaxing limbal incisions on 50-year-old patient or 60-year-old patient. The patient were coming back to accommodation, and after 6 months they were come back to the previous situation. But just making an incision of the sclera, you create a little bit more space that permits the ciliary body to push forward. That makes probably a role, or plays a big role in accommodation that we are not aware of. Something that deserves to be studied a little bit deeper. The very easy question is, if the sclera is moving during the accommodation, is the cornea doing something? It's true, I know, that there is no positive bibliography for any change in the cornea during accommodation. All the wavefront studies said that the cornea remains in the same shape no matter what if it's near or far. But having that movement of the sclera can we expect to have some movement or some contraction or change in the shape of the cornea and the accommodation? That's a question I have. I don't know the answer. Okay. Based on that, this is what I'm not being lucky with my video clips. Okay, this is not really relevant. This is just a capsular bag just to show you how we can picture the sonula of you and I, and how we can measure the posterior capsule dimensions, iris volume, which is going to be relevant. Again, the same four pictures. Don't try to watch the same thing, to look at the same, the four at the same time. Just go one by one. Those are accommodated human eye showing crystalline lens changes and ciliary body contraction. Again, I said it's probably a very bad idea to put the four of them just in motion at the same time. Okay, this is not really, well, we already shown you that. Let's go to next. Those are some accommodative IOL moving. The ones on the top is the lensed tetraplex. The lensed tetraplex is just a little bit changing the distance between the iris and the lens. The whole anterior uvea is pushing forward. That is creating this image or illusion that the lens is moving. It's not an illusion, the lens is moving. Down there is a crystal lens, AT45, the previous model of the crystal lens. And here is the only lens that is doing clearly and with no doubt what the manufacturer pretends. Take a look at this video clip and see synchrony, the dual optic Visugen IOL. As you probably know, it's a two-piece lenses. It's a negative lens that goes on the back. It's a positive lens that goes on the top. And they compensate each other, and the slightly differences between the two lenses create like a telescopic effect or the zooming effect you have on your photo cameras. This change of distances between the two lenses are reverting on a very high diopter change, which justifies the near vision diopter addition that every patient has or needs. Then, if you see the lens is clearly moving and creating a larger space here between the two lenses implanted here. It's coming in only in one piece. You don't need to implant two lenses. It's only one piece and you implant one. The lens itself is two lenses. It's constructed or built as a two lenses, which is a pretty impressive video clip showing clearly how an intraocular accommodative IOL moves exactly in the way that the manufacturer describes. Okay, here is another accommodative IOL. This is a crystal lens. As you see, the lens is clearly moving. If you have any doubt about that, look at the haptics, how the haptics are bent during the process. It's really, really nice to see a very clear movement of the lens forced by the stimulation of the fellow eye on the accommodation. And as you can see, the lens is moving backwards instead of moving forward. Means it's going opposite on all the effect we are looking at for. When the pupil closes, which is supposed to be part of the triad, it's miosis, convergence, and ciliary body contraction. The lens is moving backward. How does it come? That means the lens is going against the power that we are looking at for near vision. It's true, the lens is bringing you the illusion that it's moving backward, but it's not really true. Measuring these distances, endothelium to the anterior surface of the lens is moving backward a little bit, just microns. But it's not really the main situation over here. It's the whole anterior uvea pushing forward. Means that the whole ciliary body moving forward forces the lens to remain down where it is, where it has been originally placed. Which means that the effect of accommodation that this lens has, it may need to have a different explanation than the one that has been provided. Because this patient is a happy camper. He reads J1, J2, J3, I don't remember. He's not wearing frames. He's reading without lenses and having a perfect 20/20 vision on far vision. Means that it's a perfect patient, it's a perfect movement, but we cannot find an explanation why this lens is moving. It's completely different than this gentleman that I showed you before, where the lens is clearly justifying the power change based on the physical movements responding to the ciliary body contraction during the accommodation. Let's get back to this gentleman that I don't really can explain why this patient is breathing. And let's do some measurements. I won't go on the measurement, but look at the maximum and minimum accommodation and disaccommodation of this eye. Sorry about the background noise. It was snowing that day. And all the measurements explain that there are clearly changes inside the eye. It's not probably justifying based on what we have known, what the manufacturer pretends. It's not clearly justifying the diopter change, positive diopter change for near vision. And this is it. Finally, one video clip, just the last one showing how a human eye going to be changing during accommodation for near and far vision. Interesting to say that to do those kind of human accommodation clips, we need to really do a very complex setup. Nothing very complex in technology. It's very complex to try to make the patient understand what you're asking him to, because we need 6 meters far target and a 33 centimeters near target that we used to do through a mirror. The mirror must be perfectly placed on focusing the target at the 6 meters for the patient avoid the convergence. Other way, when you are capturing the eye is moving, it's a little bit complex to show. It's not for the daily practice, but it's very nice to do some kind of research. Thank you very much.
Thanks.